let's move on to perhaps one of the most exciting therapies to land in the lung cancer space ever. Nivola Map and pembrolizumab have been complete game changers for the treatment of not just squamous non-small cell lung cancer, but I'd say all non-small cell lung cancer. I would argue that every patient who is a candidate for these drugs received them, either adenos or squames, either under the umbrella of a clinical trial or as standard of care. But we'll focus a little bit on the data with squame today and talk about two of these drugs, Nivola Map and pembrolizumab. And interestingly, these drugs are showing gangbuster survival advantages in phase 3 studies, but also come with their own AEs that we have to reacquaint ourselves with and learn how to manage. So I'll briefly go over the Nivola Map data, and then maybe I can get your both of your impressions on the data. Checkmate 017 compared Nivola Map versus docetaxel in a chemo-refractory patient population that was squamous cell. And we saw the triple threat. We saw an improvement in response rate, we saw an improvement in PFS, and we saw this improvement in OS with a hazard ratio that's getting to hazard ratio levels we don't really see of 0.59. We saw that the grade 3-4 AEs were much more manageable in the Nivo arm, obviously, than the docetaxel arm. And I think importantly, PD-L1 was neither predictive or prognostic of the effect that we saw in this study. And I'm certainly we'll get to PD-L1 and if it is a meaningful, useful biomarker for the selection of patients. So clearly game-changing. Also in its design by not employing docetaxel plus Nivola Map versus docetaxel. I think that was the beauty of it, is that patients were randomized to a non-cytotoxic drug arm, and that arm did show a robust survival advantage. So maybe I can get both of your thoughts on this and where we see this heading and the future of Nivola Map in squamous cell population or checkpoint inhibitors in the squamous cell. Ed?
So I don't want to I don't want to diminish the impact of what immunotherapy has done as far as our perspective as clinicians, our perspective as patients, as far as opportunities. When you still look at the raw numbers, they are good. Yeah. They're positive. But, this is not EGFR mutations and erlotinib or gefitinib or afatinib. And I think our excitement has been primed by the previous success in melanoma and renal cell. And again, I think they've made a major clinical impact, and we certainly use them and encourage people to use them. But I don't want to put a ceiling on these drugs because of this excessive hype and, the thought that everybody's going to do well on them. When you look at the numbers, 9.2 months median survival is good compared to a docetaxel arm that was just squamous. Again, in the ramucirumab data, in both non-squamous and squamous, it was 9.1. So, I think you would expect a median survival in squamous patients of somewhere between 6 and 8 months. Yeah. This is better, but it's not 15 months, it's not 20 months, and so the response rates are decent. But again, Paul just quoted a number in squamous with a response rate of a combination. So I think we have to put them in context. What makes them really attractive to me is the lower side effects.
Right.
They are so easily taken as long as you're monitoring the right endocrine labs up front. That is what makes it very attractive over a cytotoxic. And to me, that aspect of it is more of a game changer than the actual efficacy numbers.
Yeah, I'd piggyback on that just in the setting of a patient who has a response. Some of these responses are so durable, and that's something that we just haven't seen in the squamous cell population, median durations of response of over a year. I agree with you, 20% response rate, that means 80% are not garnering a benefit up front, although they may have stable disease. I'm not sure response rate is the best surrogate for this drug, because we've had many patients on trial who haven't had a response, have had stable disease, but their tumor has just halted. The brakes have been put on, and there's no further growth. So I agree. I think everything has to be put in context. These are not cures. Historically speaking, though, we have not had a drug like this in squamous cell in quite some time. It's a welcome change, and mostly, I think, patient-centric for the AEs.
And again, based on the chronicity of which you can deliver this drug,
Right.
because it does not confer a lot of side effects, you can give patients this drug for years, which is very unusual for any other therapeutic that we'd have.
Yeah, it's patient-centric not only in its AE profile, but in the fact that it actually harnesses the patient's own immune system. And I think patients are behind this, advocacy groups are behind this. Paul, your thoughts on this drug and your use and where this is going?
So yeah, we use it quite a bit. You know, it is the de facto standard now in the second-line setting for patients who can take it. But I think, you know, Ed is completely right. I think
I didn't pay him to say that.
no, there's been a lot of positive press out there from any number of groups, and not just industry, about this class of medications. And while I think it's definitely warranted in melanoma, right, where it approaches the efficacy that we've seen with targeted therapy, we haven't yet seen that for non-small cell lung cancer. The attraction, of course, has to do with the subset that have this very durable response, which we rarely have seen. And as Ed had said, I mean, the rate of grade 3/4 toxicity for Nivola Map over docetaxel was almost 9 times less. I mean, that's enormous. 55% rate of grade 3/4 for Dosi, 7% for Nivola Map. And so that's astounding by itself. I think what this speaks to is a lot more effort. I know we're going to get into this in a little bit, but a lot more effort needs to be put into place, and people are doing this now, to figure out exactly who the durable responders are going to be, and to figure out whether or not we can manipulate sort of that microenvironment and whatever the patient's own immune system complexity is to gain that for them. I think that really is the next step. So this is really the tip of the iceberg, which is a good tip. But there's a lot more depth, I think, that's there.
Right, so I think I'm hearing from both of you, exciting, but let's remain grounded about this drug and what it can and cannot do.
I've called Nivola Map the new docetaxel because you can use it in anyone, and it does better than what docetaxel did back in 2000 when it was first approved based on Francis Shepard and Frank Facella. But I want it to be a docetaxel plus.
Right.
I want there to be a biomarker subset that is enriched that we routinely go after to try and improve things with, because if we're just satisfied that give it to everybody and some of them will do really well and a lot of them won't,
Right.
I don't want that.
Right.
I think we're taking 2 steps back if we accept that.